Hello and good evening and welcome to Gastro Learning Live. Now, we go far and wide globally to get the experts to join us for these sessions. And on this occasion, I've looked about 4 feet sideways to my fantastic colleague, Dr. Gavin Johnson. With whom we're going to discuss the topic of pancreatic cysts. Now, Gavin, we spend several hours on a Wednesday morning looking at a whole range of pancreatic biliary problems, but I think it's fair to say that the topic that makes us feel least comfortable is the cases related to asymptomatic pancreatic cysts. And I think we get excited and we have quite a good idea what we should be doing when the cysts are post-pancreatitis and related to pancreatic collections. And we'll largely leave that topic for another day. Because there's enough to talk about with regards to non-inflammatory pancreatic cysts. So it's fantastic to have you with us. And I wonder if we could just, start by getting your overview of how we should be thinking about pancreatic cysts.
Yeah, thanks, George, and thanks to the Gastro Learning team behind the scenes for getting me on tonight to talk about a topic that's indeed is massive and evolving. I think it's fair to say there's still lots of work going on into how we can improve the diagnosis of pancreatic cysts and furthermore the treatment of them, avoiding surgery, and we'll touch on a bit of that tonight. And you're quite right, it is a massive problem. If you're going to do an MRI on somebody or a CT on somebody, up to 15% of those individuals will have some sort of pancreatic lesion, cyst, if you like. Which is a huge volume of work. That's obviously more likely the older you get. And it can throw up all sorts of surprises. It creates an awful lot of anxiety for patients and it creates an awful lot of work for our MDT. And this morning, our benign MDT at UCH now runs to 60 patients. That's pretty typical. And I was counting this morning with tonight coming up and there were 15 pancreatic cysts. Not all of them very taxing in terms of getting us energized, if I'm honest. They didn't take ages, but 2 or 3 of those, there's enough mystery about the history or the imaging to warrant further investigation and so on. And we're going to go through all of that today in terms of what our thinking algorithms are. So to chat through the classification of pancreatic cysts, I think we've got a slide just to set that scene. So these are the WHO classifications. I've always found this topic fairly dry. You've touched upon the inflammatory ones. So these are the pseudocysts and walled off necrotic collections. And for those, there needs to be a fairly clear history of chronic pancreatitis or recent acute pancreatitis or both. And we're going to leave those for today. The right-hand side is pretty hen's teethy stuff. There need to be something on imaging there that would warrant EUS and probably come up on cytology for malignant non-epithelial cysts. The second column, the non-neoplastic, these are the true cysts. They're actually not desperately uncommon, but they're going to remain stable on imaging and probably not come to investigation, but they're slightly less common. And the ones we're really interested in and that tax us and fill our MDTs are the neoplastic cysts, meaning they're of epithelial origin with the potential for malignancy.
Can I just stop you there? Just briefly, that in most of our practices, and we see cysts in lots of parts of the body, in the liver, in the kidneys in particular. The vast majority of those cysts are entirely benign, simple cysts that never need any ongoing follow-up or detailed assessment. And it's a different story in the pancreas, isn't it? And the true simple cyst in the pancreas is actually quite a rare thing.
No, and that's a good point. And today in our MDT, now that people can book on patients directly, and we need to start triaging them probably, we had a couple of cases referred with hepatic cysts on ultrasound, which is, of course, something of a nonsense. But these are the reports that come back to people, and there needs to be the education about that. But you're quite right. You should not walk past a cystic lesion of the pancreas assuming, and I think this is where this should be the first question for anybody considering what to do with pancreatic cyst, is if it's going to be surgically manageable, is that patient surgically fit for anything? If you're finding a pancreatic cyst in an 85-year-old and it's small, then you need to think again as to whether there's any point sort of pursuing that. So that's an important point. But you're quite right, pretty much everyone else, there should be a considered MDT discussion, or at least a considered specialist opinion on the appearance of a pancreatic cyst. So a point well made.
And outside of the inflammatory cysts, is there anything that we can glean with regards to symptoms? Because, is it fair to say that the vast majority of pancreatic cysts, whatever their etiology, other than post-pancreatitis, they tend to be entirely symptomatic entirely asymptomatic, unless they are absolutely enormous?
Correct. And that's where jaundice comes in, which is a very high predicting factor for malignancy. And about 50% of patients presenting with jaundice with a pancreatic cyst will have a cancer or at least high-grade dysplasia. Although it has been known, it's not uncommon for a mucinous cystic neoplasm to present with acute pancreatitis. So you really need to have your antennae out for the unusual presentation of pancreatitis, perhaps if there's no other risk factors for acute pancreatitis, no gallstones, no alcohol, and you see a cystic lesion, potentially one that's impacting on the pancreatic duct, causing some obstruction, then just have your antennae up that this may represent a mucinous cystic lesion that would require further evaluation. And I think we could probably both remember 2 or 3 patients who had side branch IPMNs, otherwise entirely trivial, never are grounds for resection, which we're going to go through later, and literally presenting every 2 weeks with acute pancreatitis, had a left-sided pancreatectomy and were cured of their acute recurrent pancreatitis. So that's uncommon, but occasionally these small lesions can be the driver of pancreatitis, but that's less common.
Okay, so we've sort of set the scene. The crucial question for many of these patients is what the algorithm. They arrive with us, we have a scan. It'd be useful to discuss the vexed issue actually of the management algorithm for these cysts, because there have been lots of guidelines, and in fact we've tried to amalgamate, haven't we? Simon Philpott, one of our fantastic fellows, has come up with this, which it has to be said isn't the gospel truth, because nobody knows 100% what we should be doing. But do you want to just take us through this, Gavin, and how it helps in the management of pancreatic cysts?
So where a lot of the guidelines fall down and become difficult, and the flow sheets become difficult, is that they sort of start assuming the lesion is mucinous and therefore requires following. So just to really cut down to the chase here, what we're essentially looking for is a cystic lesion that is mucinous. It could either be a mucinous cystic neoplasm. I think we've got a single slide on that, which is usually more common in females, classically in the body or tail of the pancreas. They are unilocular, and they can often be mistaken for pseudocysts. But if there is no history of acute pancreatitis, you should really have your antennae up that this could be a mucinous cystic neoplasm or an MCN, particularly in young females without a history, because these have a significant malignant potential. So we need to find them. And we also need to find the IPMNs, which are much more common. And these are the ones that really do fill up our MDT. Again, they're equal sex distribution, male and female, classically patients over 40, so uncommon in young patients. And they can be the branch duct. These are the little small things seen in the pancreatic parenchyma, which always, by definition, must communicate with the main pancreatic duct, because that's pathognomonic, because the pathology is that these are papillary neoplasms of the ductal system. So they need to be in communication with the pancreatic ductal system. They may be main duct, as depicted on that MRI, at which point they're producing so much mucus, you may get that classic fisheye ampulla, as seen on that endoscopic image, which is in fact quite rare, even with quite sporting main duct IPMNs. We don't always see that fisheye papilla, or they may be mixed. And if you've had one lesion, you may get others. So even if you have resections for IPMNs, you need onward surveillance, as we'll come to. So then back to and then one slide more is on the serous cystic cyst adenomas. These again are more common in females, often more elderly females, and they often have this classical appearance. And of all the cysts that you can be confident about diagnosing on imaging, your classic SCN may have all the features on imaging of it being an SCN, and you may choose to take evaluation no further. These are importantly not with malignant potential. I think they have been reported, but essentially you don't need to worry about SCNs, and that's why it's so important that you differentiate them. They are, on pathology, they are very easily differentiated in that the lining of these cells are cuboidal, and importantly, if you stain for glycogen, the cuboidal cells of the centrosiner cells are glycogen rich, and that's important. And classically, they have this microcystic appearance with a central stellate scar. However, they don't always come as beautifully presented as those two images.
And
those two images, you might be satisfied on imaging, on morphology alone, to say that these are serous, but the vast majority of cystic lesions do not get easily classified on imaging alone, if that follows, particularly the oligocystic ones. And
I think it's worth making the point, isn't it? There's a very nice guideline from the AGA led by Anne-Marie Lennon, and in that they make the point that on MR alone, MR was only able to truly characterize the cyst in about 50% of cases, and differentiating benign from malignancy, again, in only between sort of 50 and 75% of cases. So we are increasingly reliant on high quality cross-sectional imaging, but even then, it often doesn't make the distinction, and that's where just having the algorithm, starting from the position of how to manage an MCN is all very well, but that isn't how these patients come to us. Exactly. They come to us as a cyst that goes through the MDM. So how in terms of duct and size criteria, Gav, how does that help us?
So back to this, we see a cyst. I think it's important they have good axial imaging, as you've said. CT probably isn't enough. I think you want to really delineate the main pancreatic duct, determine if the cyst communicates with the main pancreatic duct, if it's a side branch IPMN. So you really need an MRCP. If at that point you see a solid component to the cyst, or the main pancreatic duct is more than 10 millimeters, or the patient is jaundice, there's up to a 90% chance of that patient already having cancer. And that should go straight to a malignant MDT. And if they're fit, they should consider surgery. But that doesn't apply to many patients, let's face it. So then in our practice, we have a benign HPB MDT because the malignant MDT is full of actual cancer, not what might be trivial pancreatic cysts. So they come into our benign MDT. And then what we're looking for is those features that might represent relative risk of cancer. So less risk than the pink box at the top, but still a relative risk. So your main pancreatic duct is 5 millimeters. The cyst of greater than 30 millimeters in some series may have high-grade dysplasia or malignancy in up to a third. So that's a big deal. If there is an enhancing neural nodule that's more than 5 millimeters, is there something about the cyst wall that's thickened, or is there a caliber change to the main pancreatic duct? And all of those would get us sufficiently concerned in our practice to offer an EUS. And if you're going to do an EUS with those features, you're going to do an FNA. You're not going to see anything about those cysts that's sufficiently reassuring that doesn't then offer an FNA. So you might as well put a needle in. If we can then document on FNA that the main pancreatic duct is involved, or the cytology is suspicious or definite, or we confirm a mural nodule, you're back into the high risk features with a high likelihood of cancer and off to the surgeons. But again, the vast majority of those will be no. And that's where we need to make the diagnosis of an undefined cyst, SCN, or a mucinous lesion. And if there's been a history of acute pancreatitis, and that may be borne out when we dig a little deeper following the HPB MDT, then it's likely to be a pseudocyst, and then you get into drainage, observation, etc. So just to enhance the diagnosis, and how do we follow the no diagram and be more confident that this is either undefined, serous, or mucinous, that brings us to the role of EUS, for which I think we have another slide. And this may interest a few of the audience who are EUSists who may be joining us tonight. EUS has the benefits in terms of imaging in that you get beautiful high resolution images of the cyst. You can determine how big it is, obviously no better than axial imaging potentially, but you really can delineate its relationship to the main pancreatic duct. Are there any nodules? And if you see a nodule, just beware that it may be mucus and not in fact a soft tissue nodule. And for that, there may be the role of ultrasound contrast. We use Sonoview at UCH. And if the nodule enhances, then you're looking at an enhancing nodule and not a lump of mucus, which is important. So some guidelines.
Just to say, just on that point, we have over the years seen patients, particularly with the question of IPMN, who have a significantly dilated pancreatic duct and on cross-sectional imaging have what appears to be perhaps soft tissue within the duct. And it can, on cross-sectional imaging, be, and perhaps even on EUS, be difficult to distinguish from soft stone, because, of course, the management may be utterly different between the patient with a largely asymptomatic dilated duct due to chronic pancreatitis versus an IPMN with nodules. So, do you think that Sonoview should be a sort of standard, or contrast media should be standard in these settings?
So, full disclosure, we don't always use Sonoview for every evaluation of a pancreatic cyst, but you'll go to live courses and hear other experts who say it probably should be part of the evaluation. If you go into all the trouble of doing an EUS in patients with those features, size, etc., then there is an additive role of IV contrast to enhance the ultrasound to find those nodules. But full disclosure, we tend to troubleshoot with it at UCH in terms of time and so on. So yeah, an interesting topic. I think given that we've already told you that you can't decide what the lesion is by looking at it, and if there are suspicious features to get you to do the EUS in the first place, such as size, then you're really going to want to do an FNA. So that's useful in that it gives you an idea of the viscosity of the fluid. You could read about string sign, which is where you pull up on a glass slide and get a 10 millimeter rise in the viscosity of the fluid on your glove. Again, it's not perfect, but if string sign's positive, it's suggestive of there being a significant mucus component to the fluid. Obviously, if gross mucus comes out, as you often see in MCNs in young females, you've got the diagnosis, it's an MCN, and you can be happy. You're going to test for amylase. You're clearly going to send that fluid for cytology to look for suspicious cells, but very often it just comes back as bland and not particularly helpful. And that's where we get into other features of the cystic fluid and whether that can point towards a serous cyst that you can discharge or a high-risk lesion for mucinous that you need to resect or keep a close eye on. So CEA was first described in 2004. Sorry, George.
Yeah, no, I was going to say, tell us a bit about CEA, because it's it's an unusual sample for labs to receive. And there's always a bit of concern that the standardization of measurement of cyst CEA is variable at the best.
No, and that's one of its criticisms is cost, availability, and reliability of that actual result. Never mind what that result means, but even the result you're seeing in front of you has been brought into question. I tend to take the result on face value, but you make a very good point, which is why research is going on into better ways of determining cystic versus mucinous versus serous. Yeah. So this is a bit of a précis of the CEA data of fluid. So this was a bit of a breakthrough that the number in our heads for many years was 192. This was Bill Brugge in 2004, sensitivity of 75%. And remember, sensitivity is the ability of a test to correctly identify a disease. So a high sensitivity means you're finding the cases. Specificity is correctly identifying no disease. So a high specificity means you're not missing cases. So on the left, a high sensitivity means you're going to be doing appropriate resections and finding cancer and curing patients. And on the right, a high specificity means you're correctly finding patients with no disease and you're not doing inappropriate surgery on serous lesions, essentially in this context, just to sort of remind us what these numbers mean. However, subsequent studies, and there were several of them, really did bring into question this threshold of 192 with really insufficient accuracy, misdiagnosis of mucinous lesions of up to 40%. What you then do is move the threshold. So if you've got a threshold of 800, you're going to clearly find lots more cancers, but rather you're going to resect lesions that are pretty much always mucinous, but you're going to miss a lot of mucinous lesions with a much lower CEA. So that's not very satisfactory. If you drop the CEA to 105, you get the reverse problem. I think the one role for CEA is that if it is very low, i.e. less than 5, the specificity is about 95%. So if your CEA is really low, you might take that on with other clues that this is in fact serous and leave things alone at that. But CEA is not perfect. And that brings us on to glucose. And I wouldn't be at all surprised if in the next iterations of international guidelines, we're starting to see a low fluid glucose as a pointer towards it being mucinous. There's 2 papers in ePrint already in GIE. They're not yet in published print, but they're available. McCarthy and Fias. These are both reviews and meta-analyses up to 609 lesions, really showing far superior sensitivity and specificity than CEA. So I wouldn't be at all surprised if this hits the mainstream, because it's pretty straightforward to get a glucose reading. And the threshold seems to be 50 nanograms per deciliter, I think. So watch this space for glucose.
And and glucose, if it's borne out, that would be much more accurate than any, shall we say, cell sampling technique. I mean, there are intracyst biopsy techniques, etc., which can be used, but it may well be that biochemical sampling is going to be more accurate.
And which would be preferable, because biochemical sampling is not going to raise the risk. So there is confocal, lots of intra-observer disagreement about confocal. You're relying on your interpretation of imaging of a papillary line cyst, which is an IPMN, versus the classic ordered cuboidal appearance of a cystic lesion. So that's a sort of in vitro diagnosis. And then what I think might find a role in a niche setting is the use of microforceps, which is where you get a 19 gauge needle into your lesion. You pass these tiny forceps through the 19 gauge, and on EUS guidance, you can just see the cyst wall tent up towards the needle, and you get these little biopsies. And again, what you're looking for is glycogen staining. Is this glycogen-rich cuboidal cells? Is it a serous lesion? Can we discharge? And I expect where they may come into an algorithm is your oligocystic lesion in a young female, where it's perhaps in a high-risk area. It may mean a Whipple rather than a left-sided pancreatectomy. And if you really want to force the envelope, does this patient need a Whipple for a high-risk mucinous lesion, or is it a serous oligocystic, serous cystic neoplasm? Then there may be a role for microforceps, but there is a pancreatitis risk with that, and it's not yet ready for mainstream in terms of an algorithm. But watch this space on that. That may be interesting.
And Gavin, we'll need to move on to issues around IPMN, surgery, and surveillance. But just a couple of words about EUS guided ablation. Is that going to prime time?
Yeah, so work has gone on with the use of ethanol, lots of studies on that, but it does not seem to be successful in mucinous lesions. So some report an 11% success rate for IPMNs. That's no good with a pancreatitis risk. Paclitaxel is being looked at. It seems to spread a little better. It's more hydrophobic. But Prof. Pereira is busy putting the finishes touches to radiocysts. So he's our colleague at UCL. Yep. He's recruited 80 of 97 patients, multi-center across the UK. Many people online may have contributed. Watch this space. If we can successfully ablate these things when they're small, when we're sure they're mucinous, it would be a nice development.
Okay, yeah, great. And we've spoken a lot about MCNs and differentiating those, importantly differentiating from serous lesions. Let's move on, if we could, about IPMNs, intraductal papillary mucinous neoplasms, both in terms of their assessment and with that management.
Yeah, and again, we've got the slide that is pulled from the European guidelines of 2018. If we could put that up. And this is when you're sure you're looking at an IPMN. What do you do about surveillance? We've already talked about when to think about surgery. And just a reminder, an absolute one is positive cytology, mass, jaundice, big duct. They go for surgery. But the relative indications are growth rate. If you're, if the if the lesion is expanding by 5 millimeters a year, it's very suggestive of high-grade dysplasia or cancer, even if it's quite small. And that reminds us that if you've got an index scan or the first scan of a patient with a reasonable size cyst, you don't know the rate of growth of that thing, and your first follow-up should be a little bit more intense. So if you follow the left column down, so this is the intensive surveillance group, so clinical evaluation, a serum CA19-9 in that over 37 may be suggestive and a relative indication, and a repeat MR at 6 months, not at a year, but at 6 months, just to see the rate of growth. And if that cyst's got significantly bigger, it again is a relative indication for surgery, even if it's not yet at the size criteria of 40 millimeters.
Conceptually, I've always had a little bit of a problem with that, because you're not talking about the growth of a lesion, you're talking about the increase in size of a cyst. And it's always struck me that that must be dependent in part on the degree of communication to the main duct and the degree of viscosity of the contents of that cyst. And the volume of mucus they're producing to expand the cyst. Yeah, I agree with you. It's peculiar, but that's why size is certainly not everything when it comes to cancer risk, as the studies bear fruit to. But the majority of your patients will have no indications for surgery. But unlike the criticized American guidelines of some years ago that talked about discharging at 5 years, I think what's pretty much come out now is that that was significantly criticized. And the European guidelines, just as you wouldn't discharge any other pre-malignant condition, you shouldn't be discharging cystic lesions that you think have the criteria for being IPMNs. And that's where your service needs to be doing annual MRs. Obviously, if you've got greater EUS capacity than MRI capacity, then you could be doing those. I'd certainly want an MR over an EUS if it was me and I was the patient and we do MRs. But actually, don't forget about CA19-9. Again, I'm not sure we're as strict as that when they come in for their MRs, that we're doing CA19-9s every year. There's a great question from the audience, Gav, which we should address, which is approach to counselling patients about cancer risk when surveying these cysts. What risks do we quote? And the question we have every week is, when do we advise stopping surveillance? You know, are we committed to 50 years of annual surveillance? Great questions. I mean, how would you respond to those?
So the first question is, if you've got a branched duct IPMN, side branch IPMN, about 10 to 15% of those will grow and therefore possibly develop other features of higher risk or relative indication for surgery over the next 5 years. So you can, in the same breath, tell patients that they've got an 85% chance that in 5 years their scan won't have changed one jot, but not to totally lower their heckles, in that you want them to turn up for those annual scans and evaluations. So that's not a bad ballpark figure to have in your head, that 85%. The second question is quite straightforward, and this is why we need to see patients now and again. As soon as they're no longer fit for surgery, then the suggestion of removing lesions that may not yet be cancer, but have high risk for developing cancer, you're only going to do that in patients who are surgically fit for what will often be a Whipple resection for IPMNs. And so that's when you would stop surveillance. And the other bit of that was, I forgot what the other thread to the stopping surveillance was.
Yeah, no, I mean, I think that's, I think we need to be very clear as to why we're surveying. Essentially, we're surveying in order to have the opportunity to perform major curative pancreatic surgery in the setting of a malignant or very probably malignant cyst. And sometimes we forget about that it's, if we're following a cyst in the head, then the only curative approach is likely to be a Whipple's, and is the patient going to be appropriate for that? That's really interesting. Gab, we're in the last couple of minutes, actually. Amazing how time flies. Just shows we couldn't discuss pseudocysts at the same time. We haven't had a chance to talk about IPMNs and the role of pancreatoscopy, which one could debate on another occasion. But I just wonder, taking an overview of pancreatic cysts. What do you think would be the most important step forward in the overall management of pancreatic cysts? Is it better imaging? Is it more definitive treatment? How do you think things are going to improve over the next decade, let's say?
So in an ideal world, we'd be able to much more confidently identify mucinous lesions, so we would know who to follow. That's probably going to mean more EUS and more accurate modalities when you're doing an EUS to find mucinous. So that might be glucose, it might be GRAS, etc. It might be microforceps, who knows? But really identifying with confidence that you're looking at a mucinous lesion, so you know which ones to follow and which ones to discharge. And then at that very early stage, if there was the perfect ablation solution when they're small, that would be great too. It needs to be safe and effective, and I don't think we're quite there yet, but we look out for Prof. Pereira's data with some interest. That's probably not going to apply to all patients, however. So they'd be the two sort of dream things with regards to really giving pancreatic cysts a boost in management.
Okay. I'm pretty sure we're going to be seeing continued pancreatic cysts within the MDM for many, many years to come. Gav, we've run out of time, actually. That fantastic session. Just to say that for those watching, there's further information on the Gastro Learning site, including the guidelines that we've alluded to. There's even some nice some videos of EUS guided cyst management. So finally, I'd like to thank you, Gavin, for as expected, fantastic session, and everybody have a good evening or morning or afternoon wherever you are. So thanks ever so much.
Thanks, George. Cheers.